So there are other differences between chemotherapy and the BTK inhibitors that, let's come back to that question when we get to maybe toxicity profiles and comparing toxicities like in the ECOG and the Alliance trial. Let's move on though to talking about the second currently approved BTK inhibitor, and that's acalabrutinib.
Yeah, so acalabrutinib is approved only for mantle cell lymphoma in the relapse refractory setting. Not yet approved for CLL. There have been registrational trials, which I hear have been or are completed and may soon be reported, but no indication for CLL just yet. It probably is used in a small proportion of patients off-label, maybe in ibrutinib intolerant patients specifically, but at this time we don't have any head-to-head data or any real-world data on acala use in CLL.
So what's your experience been like in those ibrutinib intolerant patients?
I've only used it a few. I was part of the head-to-head trial versus ibrutinib, which is not yet reported, but I've used it occasionally in some intolerant patients, and for some patients it's a good answer. I think it may depend on the toxicity.
Okay.
But it's limited use so far.
Do you think there's any reason to expect, or have you seen activity of acalabrutinib in patients who've been refractory or resistant to ibrutinib?
Probably not high expectations. The resistance mechanisms to ibrutinib are still being worked out. There are CYS481 mutations in BTK, which, if they're affecting ibrutinib's binding, should probably equally affect acalabrutinib's binding. There are downstream mutations in PLC-gamma2, which is downstream of BTK in the signaling pathway, which should be independent of both drugs. I think it's still a little bit of a black box, because although people originally thought that these two types of mutations represented like all progressions, outside of transformation, it's probably not the case. Probably half the progressions that we see are not having either mutation present. So it's hard to know whether or not one drug would overcome it or not universally, but I think biologically there's a low expectation for somebody who truly has ibrutinib resistance that another covalently binding BTK inhibitor, either acalabrutinib or zanubrutinib, would overcome that.
Okay. So do you think there's a role for doing BTK mutational analysis? Do you do it?
I do think there is a role for it. I think it's emerging. There are some centers where they check patients every 3 months. The problem is that the results are not yet actionable. And so there are non-covalently binding BTK inhibitors that are in development. At least 3 companies are studying such drugs right now in clinical trials that possibly could overcome resistance in these BTK mutations. So I think it may be actionable in the future. Probably what it gives you now is a little bit of a lead time. So the presence of these mutations have been found between 6 months and a year, let's just say, to round it out, before patients have clinical progression. So if you detect a mutation, at least it gives you time, particularly for young fit patients, to start planning alternative strategies, other targeted agents, stem cell transplantation, some alternative approach, a clinical trial, for example. So we do check them in younger patients, sometimes sequentially, but if there's a suspicion of resistance, then we check it when we think about switching patients. I think biologically, you could argue maybe PI3K inhibitors would have a role in BTK mutated patients more so than PLC-gamma2. If they're PLC-gamma2, there may be, or BTK, you could argue for use of BCL2 inhibitors. But I think we're in the earliest stages of working out these precision medicine pathways based on specific mutations. I think it's a couple years away.
That's interesting. Okay, and then the drug that's might be on the horizon, and that's zanubrutinib?
Yeah, a drug that's really been studied in a limited number of patients, at least reported in a limited number of patients with CLL. Like acalabrutinib, the early data looked to be well tolerated and active, with response rates for both drugs exceeding 90%.